Okay, so today what we're going to do is we're going to go over some dermatology. It gets pretty heavy, so hang in there. We'll tie it all up at the end, but for now we're going to cover pretty rapidly a whole bunch of topics in dermatology. This topic, this particular lecture covers acne, skin cancers, and a whole bunch of other kind of miscellaneous dermatology information. All right, so Derm 2. Things to know about dermatology. Well, derm is about rules and repetition. A lot of times in dermatology, you're describing various lesions. So you want to be able to follow a certain criteria that you use each time so that you don't miss things. You also want to see as many rashes and lesions as possible, particularly while you're a student. So the more you see, the more that you'll learn. You also need to know when to refer people, and also it is important to read the referral notes and the pathology reports, as you can pick up a lot of really good information in these reports themselves. Trust your gut, and if you want to consult, make sure that you have that consultation performed. Always document who you consulted with. And up to date is a collection of what physicians have agreed upon based on research, but it is definitely not the only way to treat things, and there are going to be preceptors that do things differently throughout your career. So the objective topics for this lecture are fairly broad. So we're going to cover acne, vulgaris, acne rosacea, alopecia, subungual hematoma, leukonychia, onycholysis, onychomycosis, paronychia, felon, condyloma, molluscum contagiosum, folliculitis, furuncles and carbuncles, erythema, tinea, a whole bunch of different types, basal cell carcinoma, squamous cell carcinoma, melanoma, and then a total body skin exam. So what does PANCE care about? Well, here's the PANCE blueprint for derm. It's actually fairly robust. I'll let you guys read through this on your own, but always keep the PANCE blueprint in mind, and we'll make sure that we cover these topics throughout this module. So PANCE still cares about your keratotic disorders, pigment disorders, which we'll talk about some today, and then other dermatologic disorders, which we also hit. So just to be aware, there are a lot of PANCE topics that are covered in dermatology, although that's only 5% of your exam, so that makes it difficult. This is just a diagram of some of the typical places where we see lesions that are associated with dermatology, so it is good to keep these in mind. I'll leave this, you guys have the PowerPoint, so it'd be a good idea to maybe go over these, but these are the typical placements of these particular pathologies on the front and the back. All right, so basic anatomy of the skin. So you guys did the anatomy drawing exercise. There's no real need for a huge anatomy and physiology lecture in the skin, but you do have to have a basic understanding, as a lot of the pathology derives from changes in normal. So this is just kind of an overview of the layers of skin. When taking a history for dermatologic complaint, we want to make sure that we get the patient's past medical history, any medications that they may be taking, a good family history, what they do for work, their diet, as this may cause systemic manifestations, any travel or exposures that they've recently had. In the physical exam, it's helpful to use a criteria, which I alluded to before. This here is the MAD criteria. Morphology is the type, the lesion, the color, elevation, and margins. A is for arrangement, whether it's single or grouped, and then D is distribution of where the lesions are actually located. And, is it just over the arms or is it over the entire body? So those are things that you want to make sure that you include in your assessment and your documentation. There are some special tests. There's this derriere sign, which means when you rub the skin, it causes an urticarial reaction. The Ausputz sign, which is a pinpoint bleeding when you remove the scale. The higher yield here is the Nikolsky sign, which lateral pressure to the dermis causes separation from the dermis, which is obviously not normal. This photo patch test is a separate test. It checks for photo allergies. There is a patch test that's performed on the patient's back that looks for hypersensitivity reactions. The Koebner phenomena results in a lesion forming at a site of minor trauma. There's a chagrin skin, which is associated with tuberous sclerosis. It's a type of morphology of the skin that is associated with tuberous sclerosis. And then another high yield is this Schenck smear, which identifies Schenck cells, which are associated with herpes simplex virus. Nomenclature for skin lesions. This is your morphology category. So it is important to know these. Macules are flat. They are less than 1 centimeter, and then a patch is flat, greater than 1 centimeter. A papule is a small pimple-like raised palpable lesion that's less than 5 millimeters in diameter, whereas a plaque is a solid raised palpable lesion that is greater than 5 millimeters in diameter. A nodule is a solid palpable lesion that's mostly beneath the skin surface, less than 2 centimeters in diameter. A tumor is solid palpable lesion mostly beneath the skin surface that's greater than 2 centimeters. A vesicle is fluid filled, less than 5 millimeters. A bullae is the same thing except larger. And then petechiae are these tiny red macules due to extravasated red blood cells into the dermis. These are non-blanching. So this is really why we document blanching or non-blanching. It is to let us know if this is actually blood that's going to the surface, or are we able to blanch that. Purpura are larger red or purple macules and plaques due to extravasated red blood cells into the dermis. This is non-branching with pressure. Wheal is transient, flat top palpable lesion due to underlying edema. This is blanching. And a pustule is a vesicle with yellow or white exudate. Some terms continued. There's also the term scale, which is a heaped up, dry, rough epithelial patch, as well as erosion, which indicates that there's a deficit to the epidermis, and then an ulcer means that there is a deficit to the dermis and beyond. Lots of new terms in dermatology that makes dermatology difficult. It's kind of like learning another language. So acne vulgaris. Acne vulgaris is a disease of the pilosebaceous follicles. There's 4 main uh, pathologies going on here. You've got follicular hyperproliferation, so where the follicles are occurring or getting larger. You have increased sebum production. You have the increase of the bacteria that live in there, the Propionibacterium. And then this all can trigger a cascade of reactions that can occur causing inflammation. So you get this increase in bacteria, and then if these follicles should rupture, then they irritate the tissue underneath, causing a cascade of reactions to occur, activating complement, and then causing an inflammatory response. So acne vulgaris, there's no single standardized grading system for the severity. However, there are a few grading systems that we rely on. Other professionals may use separate grading systems. So we want to always classify the type and the severity. So the type is going to be comedonal, papular, pustular, nodular, or cystic. And the severity is going to range from mild to very severe, with moderate and moderately severe in between. So non-inflammatory acne vulgaris are what we call whiteheads. So it's mild. They develop over a site, and they do not cause redness or swelling, and there is definitely no inflammation associated with it. So there's an accumulation of sebum and keratinous material that converts into a microcomedone, which is the white head portion that covers it up. It's thinned, and it's a roofed papule, meaning it has a top to it. The open comedone is also considered non-inflammatory. As you can see, there's not a lot of surrounding redness and inflammation. So the follicular orifice is open and continues to get packed with these keratin, these oxidized lipids, and melanin, and it tends to look this dark black color, and these are called blackheads. So you've got your whiteheads and your blackheads, and then so the take home here for non-inflammatory acne vulgaris and treatment here. So for mild comedonal lesions without inflammation, we want to start out with a keratolytic agent. In this case, it's going to be a topical retinoid is probably your first go-to. You can also add salicylic acid as well. So these are your keratolytic. Keratolytic agents are tretinoin, this adapalene, tazarotene. So any of those is acceptable, but basically you want to start with a low potency and then increased if the patient doesn't have any irritation to it. So salicylic acid topical is considered a keratolytic, but may be less effective compared to the retinoids. So generally we go for a topical retinoid here, but salicylic acid is not incorrect to utilize. However, the topical retinoids are more effective. So for mild comedonal acne, mild inflammatory acne with or without comedonal lesions, you're going to use the topical retinoid plus another desquamative compound. And this is something that helps clean off those squamous cells. This is a benzoyl peroxide, which is a keratinolytic and a desquamative medication. You can also use a topical antibiotic, which is going to help with the infection of the propionic bacteria or any sequelae of infection that may follow. You may also add acylic acid and antimicrobial with mild comedolytic and anti-inflammatory properties. So basically, this is kind of killing off the outer layer of keratin, and that can be helpful at reducing inflammation and opening some of those comedomes up so that they can be treated properly. So inflammatory acne, this is your moderate to severe. This occurs with those papules. So these are these large inflammatory papules. They're firm acne bumps on the skin. The papules are small, less than 5 millimeters, and usually become pustules, which is called a zit. Here's the pustule. So the pustule is filled with pus. The follicles can rupture, and then they can turn into these inflammatory lesions. Inflammatory lesions are caused because of the lipids and keratins that extrude onto the dermis, not to mention the bacteria as well. So this is the nodular acne, tender, painful, inflammatory acne lesions. They should be less than 5 millimeters in diameter. They can, however, turn into cysts, sometimes inaccurately referred to as cystic or nodulocystic acne. So cystic acne is actually more severe, so we'll talk about that next. So inflammatory acne vulgaris. So this is moderate to severe. It's going to be closed epithelial line sacs. The sacs contain keratin and sebum, and this may result in post-inflammatory hyperpigmentation and scarring. So that's why we want to address these more aggressively and treat more aggressively, as this acne can cause permanent scarring. So cystic acne is a little bit more severe and can cause lifelong effects. So inflammatory acne, now we're moving on to the treatment here for our moderate inflammatory treatment. So basically you have the non-inflammatory treatment, and now you have your inflammatory moderate treatment. So moderate inflammatory acne with or without prominent comedonal lesions. You want to start them on a topical retinoid plus an oral antibiotic. Now you can add the benzoyl peroxide. Remember, that's that keratolytic agent that kind of cleans off and sloughs off the dead cells. And then you can also add the azelaic acid, which kind of does the same thing. So severe inflammatory acne, these are patients with severe recalcitrant nodulocystic acne, is generally treated with oral Accutane. We want to monitor liver function in CBC, anybody that gets on Accutane. We also want to make sure that they're not pregnant or planning on becoming pregnant, and they have to be on 2 separate forms of birth control if they're on Accutane. So here's the Accutane, the acne treatment cheat sheet. So for comedonal acne, that's your whiteheads and your blackheads, you need a keratolytic agent, which is a topical retinoid. For mild inflammatory acne, you're going to do that topical retinoid, and you're going to add a topical antibiotic. You may or may not add the acid or the benzoyl peroxide. Those are kind of a side note. I want to get too wrapped around those because you know that the retinoid and the antibiotic are indicated. And then for moderate inflammatory acne, you're going to do the topical retinoid and oral antibiotic. And now here's where you add your benzoyl peroxide and or the azelaic acid. And then for severe nodulocystic acne, it's the isotretinoin. So that's a helpful slide for kind of condensing all that really kind of vague, unclassified information into one nice slide. So there's non-medication treatments, right? We can look at people's hormone levels. We can make sure that a female, for instance, isn't producing too much androgen. We want to investigate for any endocrine disorders. Also, some facial cleansers can be irritating, so we want to go back in that history and find out how they're treating it. People that don't change their pillowcases often do have more of a chance of developing acne because the oil is on those pillowcases. So that's one thing we want to discuss with people. Also, what lotions are you using? What kind of soaps are you using? All those kind of things some people may take for granted, and they really do cause problems. You want to make sure that they avoid picking at their lesions, and make sure that you're treating them as a person too, because this can be hard on you psychologically to have these lesions. Rosacea. So rosacea is kind of one of those acne-like disorders, but rosacea is this redness on the face. There's a whole bunch of different types of rosacea, which we'll talk about. There's this telangiectatic rosacea, there's a papular-pustular rosacea, there's ocular rosacea, and there's phimosis rosacea. So we'll talk about all of them. Women are more affected, and the cause is unknown, but certain triggers have been found. So common findings is usually middle-aged individuals. The rosacea can be papular or pustular in nature. There's going to be some background erythema and then telangiectasia of the face, which is basically just seeing these really red small vessels on the face. It's more common in Celtic women. It involves the forehead, cheeks, nose, and ocular areas. So there's primary and secondary findings with rosacea. So the primary findings are basically what we see, and then the secondary are kind of sequelae to that. So primarily there's going to be some erythema. You can have some symmetric flushing. There's going to be some papules, some pustules, and some telangiectasias. And then secondary, there can be some burning or stinging, obviously. There can be plaque formation, as these people are probably trying to clean this away, and it may get dry. There may be a dry appearance. There can be some edema due to the irritation of the tissue. And then there can be some hypertrophy of tissue and scarring, which we'll see later, as well as ocular manifestations. So to diagnose this, we want to start thinking of some differentials as well. We don't always just want to jump to rosacea. So it could be an acute complication if the patient has sarcoidosis. It could also be lupus with that butterfly rash. There could be like a perioral dermatitis going on, or a seborrheic dermatitis. So those are all things that we want to keep in mind, and we don't just want to jump straight to rosacea. So this is the first type of rosacea that we're going to talk about. We'll just break it down to red and telangiectasia. So erythematotelangiectatic rosacea. So if you can say that 10 times fast, you're a better person than me. But it's persistent centrofacial erythema with no sparing of the nasolabial fold. So that sparing of the nasolabial fold is something that you see in what? All right, you see that in lupus. So if there's no sparing of the nasolabial fold, then we're more suspecting that this is rosacea. So there's these telangiectasias, there might be some flushing, maybe some dryness, maybe some sensitivity, and maybe some facial edema from all the irritation. So here's an example. So these kind of vessels that you can make out here at the surface, how these almost look like broken blood vessels, that's the telangiectasias. There's the lupus. Now in this case, it's difficult to say because it does kind of spare her nasolabial fold, but at any rate, this is rosacea. You can also see the dryness of the lips here. Basically, you're talking about a person with very sensitive skin that has this. So papulopustular rosacea looks more like acne, but it's going to be in your older individuals. It's inflammatory. So that's really the take home there. It's primarily distributed over the central face, so the bilateral cheeks centrally. And then there's some features of this erythematotelangiectasia rosacea as well. But basically, this persistent facial erythema with this flushing in telangiectasias plus the papules and pustules, and that's how you get papulopustular. So the names really do kind of give you the idea of what we're talking about. But this is the papulopustular. So you can see that there's these nodules and these kind of cystic structures, as well as the dryness and redness. So let's do a quick question here. So you have a 53-year-old male with yellowish scale-forming plaques on the eyebrows and nasolabial folds. What is your diagnosis? So in this case, we're talking about yellowish scale-forming plaques. So that takes out our papulopustular rosacea. It's also not going to fit with erythromatic telangiectasia rosacea, so we can throw that one out. We're not even talking about the paraorbital region, so that one's out, that one's out, that one's out. And then if we're talking about lupus, let's see, it's saying that it's encompassing the nasolabial fold, so that one's out. Now, I just wanted to teach you guys this. We haven't even learned this yet, okay? But just knowing what we've already learned so far, I can already tell you with great certainty that the answer to this question is seborrheic dermatitis. Well, mostly because I wrote the PowerPoint, but also because you can start ruling things out with these questions, okay? So don't back yourself into a corner. Make sure that you're taking the time to work through questions. There's always going to be one or two that are a little bit tricky, but for the most part, you should be able to start ruling things out based on the stem. So I knew that you hadn't even had this yet. I wanted to add this in there so that when you're test taking, you kind of get that idea of starting to rule things out. Don't overthink things on tests. So this is a classic distribution pattern for seborrheic dermatitis. These yellow plaques are part of the presenting seborrheic dermatitis involving the hair and eyebrows. Also hints towards the diagnosis, as does the fact that seborrheic dermatitis is more common in males, okay? So rosacea and paraorbital dermatitis do not present with yellow scale-forming plaques and involve the nasolabial folds. Lupus erythemus spares the nasolabial folds and does not have yellow plaques. So just some things to think about when test taking. So ocular rosacea is characterized by conjunctival hyperemia, anterior blepharitis, keratitis, lid margin telangiectasias, abnormal tearing. You can get some conjunctivitis, and you may or may not form some styes. Okay, so just overall badness around the eyeballs. Phimosis rosacea, so no thanks. I would rather not have my nose look like that. So this is a type of rosacea that's just terrible to have, but the skin and the sebaceous hypertrophy causes this just constant scarring and hypertrophy of tissue, and it ends up having this really crazy looking nose with distorted facial contours, especially around the nose. No fun. So let's go over some treatment principles here. So the treatment for rosacea really depends on the subtype. You know, we want to treat some of the irritation. So some medications that are used for rosacea are topical metronidazole, as well as sodium sulfatamide and erythromycin. Usually this is a triple therapy that we do. If topical antibiotics fail, you can try like a tetracycline, a minocycline, or a doxycycline, some sort of medication of that class will help. And then you can also do cosmetic agents to kind of cover it up. Laser therapy is helpful for the telangiectasias. And then you can refer cases of ocular infettomatous rosacea to dermatology. This one's probably going to go to ophthalmology as well. Okay. Okay, sorry, my computer froze up. All right, we're back. So folliculitis, it's just what it sounds like. It's inflammation or infection of the hair follicles. It can be caused by, shaving. It can also be caused by the hot tub. The most common bacterial species here is Staph aureus. Hot tub folliculitis is caused by Pseudomonas, who is the water-loving bacteria. They're either usually bacterial or fungal. Looks like this actinic type morphology. You'll see it at the base of the hair usually. And if it's a hot tub folliculitis, it can be kind of all over. So treatment is basically topical antibiotic with clindamycin or this erythromycin. It's good to know that hot tub folliculitis is almost always self-limiting. Just better get your hot tub cleaned out. And if it's not limited, then you can use a fluoroquinolone. Folliculitis, furuncles, and carbuncles. It just gets grosser and grosser. So a furuncle is just a boil that comes first, and then a carbuncle is a cluster of furuncles. So usually these are staph or strep. Usually you get this kind of small pulsatile pustular infectious process, and then it spreads from there into these nasty looking big boils. Alopecia, so this is non-voluntary hair loss. I don't know what type of hair loss is voluntary unless you get your hair cut, but it's non-scarring alopecia. Non-scarring alopecia is hair loss without scarring, inflammation, or atrophy. So that's alopecia. Scarring alopecia is permanent hair loss with tissue destruction, including scarring, inflammation, or atrophy. So hair grows in 3 different phases. You have the anagen phase, which 85% of the hair is in this phase. It lasts for 2 to 6 years. Then you have a catagen phase. This is a transitional phase, which allows the follicles to renew themselves and lasts about 2 weeks. And then the telogen phase, which the follicles are dormant, they're resting, and then about 15% of your hair is in this phase. So the hair is always going through these 3 phases, and all different parts of the hair or scalp itself are in one of these three phases. So here's kind of the anatomy of the hair shaft, right? Just a little bit of a review there, but these are some of the anatomy that's important to know so that when problems arise, you can kind of identify what you think might be going on. Causes of non-scarring alopecia, so pattern hair loss. It's just called androgenic alopecia. Hair breakage, if somebody is actively pulling out their hair, it's called trichotillomania. Or if they're eating it, traction alopecia, and cosmetic over-processing. So like if you're bleaching your hair all the time. There can be problems with cycling. You can have excess shedding, telangiectasia, anagen efflavium, loose anagen syndrome, and alopecia areata cause problems with the cycling here. And then also syphilis can cause problems. Somewhere in between those three phases, you're having a problem. Anagen hair loss occurs with anti-neoplastic chemotherapy agents. So when people lose their hair when they're going through chemotherapy, it's because the anagen phase of the hair is being interrupted. Telogen efflavium is a type of alopecia that usually causes diffuse thinning that follows a significant life stress. So sometimes I've actually seen it in clinic where people will come in after having a very stressful event in their life and they'll complain about losing their hair. So some things that you want to consider when somebody comes in with hair loss is that it could be some sort of systemic manifestation of polycystic ovary syndrome, PCOS, could be Cushing syndrome, hyperprolactinemia, thyroid dysfunction, and or iron deficiency. So causes of scarring alopecia, these are more of your infectious type processes and other pathogens, but it could be tinea capitis, which if it has inflammation, it's considered a chorion, or bacterial folliculitis. Neoplasms can also cause scarring hair loss. Alopecia mucinsa in cutaneous T-cell lymphoma, or alopecia neoplastia due to metastatic carcinoma due to breast cancer. There's autoimmune causes for scarring alopecia, which is this chronic cutaneous lupus erythematosus and lichen planus. And you can also have congenital scarring alopecia. What is alopecia areata? Well, alopecia areata is a chronic autoimmune mediated disorder that targets hair follicles and causes sudden onset of non-scarring hair loss. It's usually a patchy presentation with these discrete patches of complete baldness. Alopecia totalis is the total loss of scalp hair. Alopecia universalis, is a loss of hair over the entire scalp and body. Alopecia areata pattern typically presents with a smooth, circular, discrete site of complete hair loss. So you may just have one site of hair loss on the scalp. So you've got all this hair around it, and then you've got this basically kind of like this hole of hair growth here. Develops over a period of a few weeks and resolves within a week or a few weeks or months. So sometimes you'll see that they're already starting to grow back their hair in the spot where they lost it. Pits in the nail plate are a common manifestation associated with autoimmune thyroid disorder, so keep that in mind. Atopic dermatitis has also been linked to alopecia areata. So basically just hair loss in one spot here, and it's complete hair loss. Labs to consider for hair loss, so CBC, iron, TSH, ANA to look for autoimmune conditions, and an RPR to look for syphilis. So thyroid, autoimmune, syphilis, iron, and then your CBC, which is going to screen for anemias and infectious processes. So this is the normal anatomy of our nail. So basically you have what we call the nail plate here. Okay, and then this is the bed of the nail, right? Also, this portion here is the cuticle. Okay, this is the matrix that grows the nail is the base here in the cuticle. And then here you've got all this, you've got your finger bone or the distal phalanx. And then you have all these kind of little pockets, if you will, of fluid and different collagen supporting structures of the finger itself. So these different little pockets here. This is when a finger gets infected, these pockets get infected and they'll get big and infected. And so we have to drain through those. So it's good to know where these pockets of fat and fascia live. So a subungual hematoma, I mean, you probably all had one. Basically, you smash your finger with a hammer, the blood comes up under the nail bed itself, and you can't get to it because it's here. Now, within the first 24 hours or so, if you take either a drill, an 18 gauge needle, or a trephinator, which is this tool that has a little wire tip on it like this, and it's got a battery back here. Well, this wire tip, you push the button here, this wire tip gets just red hot, and you just lightly touch down a couple times quickly on the nail until the blood leaks out and you opened it up, and people have instant relief. So the problem with these subungual hematomas is that they're painful, and that if you don't release the subungual hematoma, they'll lose their nail. And so we come in here, if we're quick enough and the blood hasn't coagulated yet, we can trephinate a little hole there, allow the bleeding to go out, and then their nail's usually preserved. So if the blood is clotted, it won't work. You don't really have to numb them, because if you don't keep that heat down there long enough, they won't feel anything. You can also just heat up a paper clip and do the same thing. I've seen people heat up an 18 gauge needle. But yeah, should always do an x-ray prior to opening any wound. Also, it is a good idea to do an x-ray because so they've got obviously a trauma to the nail. Now, if this patient should have a fracture of this bone, right? Since there's now a hole here that we made, this would be considered an open fracture. So you'd want to cover the patient with antibiotics. Whereas if there's not a fracture, obviously they don't need antibiotics. So leukonychia, so these are just these little horizontal white streaks caused by abnormal keratinization of the nail plate. Can also be secondary to trauma, manicuring, systemic illness. There are some autosomal dominant problems that we can see, and they typically just grow out. So usually these aren't a problem, but you'll see them from time to time. I have some on my nails just from like working on my car and just who the heck knows, little traumas that occur. But anyway, can be a sign of problems if they're persistent and they continually are happening. You might want to go looking for badness. Otherwise, they're just, there's probably a story to go with them. Paronychia. So paronychia is an infection of the tip of the nail and the surrounding nail fold. So I'll show you some pictures there. Usually it's strep or staph, can also be Pseudomonas. I have never seen a Pseudomonal infection because most of them respond to your typical kind of skin antibiotic like Keflex. So once you cut this open though, you could do a culture and sensitivity to make it sure that you're covering this properly and there's no MRSA or other nasty pathogens. A KOH could also be done if it's chronic, or if the patient has chronic health problems, then you'd be more curious about a fungal infection. And if they're not treated, they can progress into what's called a felon. So let's look at these differential diagnoses for paronychia. I don't know. These are usually pretty straightforward, but could be hepatic whitlow, could be an arthropod sting or bite, could be a traumatic injury, and could be squamous cell carcinoma or a felon. So this is a paronychia. So paronychia, this one almost looks like it's probably a felon by now. But a paronychia is that this tissue is affected, and sometimes it's back here, it's infected. But what it shouldn't be is that the entire pulp of this finger is infected. This looks to me more like a felon, but at any rate, so a paronychia is around the nail, basically paranychia, so around the nail. So it's usually this. And the treatment is to incise it. So basically, however you want to do it, but generally you do a digital block here. So you put 1% lidocaine, about 2 cc's on each side, so that you numb this nerve that goes down either side of the finger. And it's the digital block. So if here's the digit, and you're going to numb here and here, kind of in between the web spaces there of the digit, and that numbs the entire finger, and then you do your incision adjacent to the nail in the nail fold. So a felon is when the pulp is affected, so that's the entire finger is affected. So you've got your nail here, right? And then this would be all this pulp here. So a paronychia is in this region, whereas the felon is basically all that tissue here is affected. And the felon is treated much differently. So the felon is an acute infection of the fingertip and space, usually involving the thumb or index finger. Basically, you get this abscess, and you've got all these little compartments. So if you look at the fingernail straight on, or the finger straight on, it's like this. There's the nail, and then there's these little compartments of the finger, septations, if you will, and these get infected. And so you've got to, basically you have to rupture all of these to get the infection out, because you don't know which ones it's hiding in. Sometimes it's caused by penetrating trauma. Oral antibiotics are the mainstay of treatment, and you definitely need to incise it. So here's how you incise a felon. So you give them a digital block. Here's the nerve, right? So at the base of the finger, you're going to come down and instill 1 to 2 cc's of Lido. Then you do the other side. You want to get this nerve numbed on either side. And then what you do is you take a scalpel, and there's a few different approaches, but see all these septations? You've got to get through them. So you actually take an 11 blade, believe it or not. You go through and through. This is a nasty procedure. I've done it a few different times. So you make your incision here, you go all the way through. Then you take a piece of gauze. You thread that gauze through with hemostats, and then you tie a pretty little bow on it. So it's tied up in a bow. And then they wear that around their finger so that this can drain for the next week. And you start them on antibiotics. So here's some different techniques. This guy's going in vertically, and then he's trimming out the septations with the scissors. That's acceptable. I just go right. See, this guy's doing it too. And there's that incision. See, so he's incising all the way through. But now what UpToDate is saying is to do a through and through. So you actually go all the way through, and then you actually take iodoform or plain 1/4-inch gauze, and you thread it through with hemostats. This is harder than you think. And you come around, and then this one comes around this way, and then you tie it up here in a bow. And you leave it for a week, and then you pull it. I actually did that one time. It's pretty brutal. Onychomycosis, so just a fungal infection of the toenail. You can try topical antifungals. They don't work very well. You can also go to oral terbinafine, but you want to monitor their liver labs and CBC. If you do that, as that terbinafine tablet can cause liver problems. Onycholysis is when the nail actually pulls away from the nail bed. So you've got your finger, here's the nail, and this nail is actually pulling away from the bed, and it's not perfusing this lower tissue of the nail, and so it turns this white color. Sometimes it can be more likely to occur if the patient has fungal infection of the nail, because they already have these thickened nails anyway. And then that causes the plate to kind of come off. Skin conditions like allergic reactions, psoriasis can cause it. Medications, most notably your tetracyclines and fluoroquinolones, can cause it. Overactive thyroid gland or iron deficiencies can also cause that. So I think a good take home is just to remember that thyroid problems and iron deficiency can cause problems with our skin and nails. Also, if you're working in a wet environment for an extended period of time, that can be problematic as well. Condyloma acuminata, so a wart, but this is an HPV type genital warts. There's anogenital keratidized skin. Common sites of infection include the penis, scrotum, perineum, anal canal, perianal region, vaginal introitus, the vulva, and the cervix. So also known as genital warts, venereal warts, or anogenital warts. Prevention is through routine vaccination in women ages 11 to 26 and men ages 11 to 21. So major manifestations, genital warts are oftentimes caused by HPV 6 and 11, so that's always good information to know. You can get these squamous intraepithelial lesions, carcinoma of the vagina, vulva, cervix, anus, or penis. So not good. Here is a picture of one such lesion. Herpes simplex, so 65% of the US population has serologic evidence of herpes infection. Can be asymptomatic. Asymptomatic shedding of virus, though, is not very common. So that means that when you're not having symptoms, you're not likely to pass it on. When you're having symptoms, then you're more likely to shed virus. Although many infected patients are unaware that they're infected, active disease causes ulcerative lesions. Herpes infection is believed to have increased risk of HIV transmission and acquisition, meaning that if you have these vesicular lesions around your genitals and you go and have sex, you're more likely to contract HIV because you have a very easy vector. So herpes 1 is more associated with oral lesions, as where herpes 2 is associated with genital lesions. However, those have made some big crossovers over time, so it's not really a hard line there. So an HSV outbreak is defined as primary if the patient was HSV seronegative for both HSV1 and HSV2 before the episodes of genital lesions occurred. Primary episode of genital HSV infection can be associated with fever, malaise, and headache. So kind of this low grade. Bleh. In addition to painful blistering genital lesions, dysuria can be severe and symptoms may last for 2 to 4 weeks if untreated. Non-primary is basically another flare or in a person with pre-existing HSV1 immunity. Treatment with an antiviral medication during primary infection lessens morbidity, but does not eradicate latent virus. The risk of genital reoccurrence is lower in those affected with HSV1 versus HSV2. The median recurrence rate after the first episode of HSV2 infection is about 4 occurrences per year. About 40% of patients have at least 6 recurrences. 20% have more than 10 occurrences in the first year. In general, there is a decreased recurrent rate over time. About 1/4 of patients experience an increase in recurrences at a 5-year follow-up. So here's an example that looks very painful. Herpes zoster viral infection characterized by a blistering rash and acute neuritis. Sorry, I had to sneeze. So this is considered shingles, usually in the thoracolumbar. Dermatomes most commonly involved. This is always unilateral. Other manifestations include involvement in the eye, herpes zoster ophthalmicus or octus, so the eye or the ear. Acute retinal necrosis, that doesn't sound good. Aseptic meningitis and encephalitis, if the persons are immune compromised, are more likely to occur. You can have some prevention with Zostavax. Is highly recommended and approved for adults greater than 50. So this is the shingles vaccine. So these are some shingles rashes. Notice that they're always unilateral. It's always going to follow a dermatomal distribution, but just on one side. So see from the midline over this way or over that way. If it breaks the midline and you've got the rash going over here too, it's not shingles. Ramsay-Hunt syndrome. So that's a syndrome that causes the facial nerve to be affected with HSV. You get a lot of pain. You can also get lesions in your ear, and you get this palsy of the face. So this drooping here and a facial palsy. So, all right. So treatment for herpes zoster. So treatment is a cyclovir 5 times a day. This is why I don't give acyclovir, but this is the primary treatment, so I didn't want to throw you guys off. Val acyclo is what I use, and that's 3 times per day, which is nice. But anyway, the books and the up-to-date suggest that acyclovir is the first-line treatment, but you're going to do that 5 times a day for about 10 days. And this helps to prevent the neuralgia as much and helps it remit a little bit faster. Pain medicine is definitely appropriate for these people. You can give them a topical antibiotic to reduce the superinfection risk. Prednisone may or may not have a role because some of this inflammation is secondary to the way the body reacts. So prednisone makes it a little bit more comfortable. There's also some other topicals that you can use, like calamine lotion or this dome burrow solution, are also helpful and may help speed recovery. Verruca, so a wart. This is not a genital wart, but a plantar wart. They kind of come in all shapes and sizes. We've all had one before or seen one. Avoid touching or pricking the warts as they are contagious. Do not share your clothes, utensils, or objects. Avoid physical or sexual contact when you have warts. Touching a wart or touching other part of your body. Direct contact with an infected person. Sharing objects and clothes with an infected person. So these are all ways to reduce transmission. The treatment for these include cryotherapy. There's duct tape occlusion, where you actually just put duct tape over the top of the wart day after day after day, and they'll get irritated enough to where the body treats it. Immunotherapy, electrosurgery, you can cauterizage. So the way I treat a wart, the way I treat a wart is to numb it up, dig it out, and then be done with it. So. Hang on here. Let me. Okay. So moving on here. So the treatment for these is they're usually self-resolving. Certain home medications work well. Also, the over-the-counter kind of keratolytic type stuff works fairly well. Dr. Scholl's, right? That stuff works. So really, anything's fine for treating these. Sometimes, like I said, you just have to cut them out. You have to numb up around the wart, and then you dig it out with a dermatologic curette. And then you can treat it with cryotherapy, and that probably works the best that I've seen. Bacterial infections of the skin is our next go-to here. So we've got impetigo, erysipelas, cellulitis, and then folliculitis we already went through. So impetigo is a contagious superficial skin infection, usually caused by overgrowth of staph or strep. This is group A. Strep is usually the cause, but it's this honey-crusted lesions. So these lesions kind of have this orangey, yellowy color. That's really characteristic of impetigo. Impetigo can be followed by a post-streptococcal infection, since it is a strep. So you want to make sure that we treat these patients so that they don't have post-streptococcal glomerulonephritis or rheumatic fever. And the treatment is really key to preventing that. These people are treated with mupirocin ointment topically. You can also do amoxicillin or Keflex orally, but the mupirocin, or also called Bacterial, is what we use to treat them. And we just want to let them know that it's highly contagious. You don't want them passing it around their entire family, as it is really, really contagious species here. So here's what impetigo looks like. There's those honey clustered lesions. See how they're this yellowy kind of material comes off. This kid on the bottom left really has a lot of yellow there, but it's not usually that impressive, but you'll see it, especially in people who have gone untreated for a long time. It can get really, really bad. Cellulitis. So cellulitis is just an infectious process that involves the skin, right? It's fairly superficial. A lot of times it's caused by Streptococcus group A, B, C, G, or F. Other times you can have Staph aureus as well. So if it's not strep, it's probably staph. Sometimes gram-negative infections can occur, but they're not super common. Oral antibiotics are often going to be able to work well for this, or if the patient is sick enough, they might need IV antibiotic. So here's cellulitis, and then erysipelas and cellulitis are two separate terms that really just indicate the depth of the infection. So erysipelas is a much more aggressive infectious process, and it's a little bit more focal, meaning that the borders are really well defined, the tissue's more edematous, and so there's a clear demarcation of where it's at. This is usually caused by group A beta hemolytic strep, and so when we see that, it helps us know that it's probably group A strep, in which case I like to give the patient an initial dose of clindamycin, because that stops the exotoxin production of a group A strep. However, that's out of the scope of this class. It's just a clinical pearl for the real world. All right, so the differential diagnosis here for erysipelas is cellulitis, obviously. Is it neck fash, toxic shock syndrome, gas gangrene? Is it an abscess? Is there a DVT? Is this Lyme disease? There's a whole host of things this could be, right? We could always write these long differentials. But here's a cellulitis on the right, which is lined out. Now, yes, they did outline this. However, this is not as sharply demarcated as this. This is erysipelas. So see how it's raised? It's almost even refractory to light, and it's well defined. Okay. So that's erysipelas, that's cellulitis. So MRSA, okay, we know MRSA. Everybody's got MRSA. You've all got MRSA growing on your skin, but when it causes infection, then it's more of a problem. MRSA tends to make these kind of fluctuant abscesses with different pockets that grow pretty quickly. Oral antibiotic, including clindamycin and Bactrim. Generally, we use Bactrim and Keflex in the outpatient setting. It's got great coverage for MRSA. You want to have them follow up in 24 to 48 hours to make sure that they're responding appropriately to infection. Methicillin-resistant Staph aureus is MRSA. And if it's nosocomial, meaning that it's hospital acquired, it's going to be probably more resistant to bacteria as opposed to a community-acquired MRSA, which will probably be treated with the medications at hand here. When you're talking hospital-acquired MRSA, you're looking for your big guns like vancomycin and zosyn. Erythasma. So erythasma is an imbalance in your normal flora causing an overgrowth of crinibacterium and then resulting in these plaques. So the way to diagnose erythasma is to use a Woods lamp, and it will fluoresce this red color. You can also see it in between the digits on people. A KOH preparation will help identify if this is a like a tinea or if it's just an overgrowth of crinibacterium. For patients with localized site, you can do topical treatment of clindamycin 1%, 2 to 3 times a day for 14 days. Erythasma. So erythasma is this type of well-demarcated lesions on the face as well. So you can also see it on the face there. So here's erythasma in the axilla and groin, and there's erythasma on the face. So not a place that you'd really want to have it, but that's just that overgrowth of crinibacterium and can be treated with clindamycin to kind of combat the crinibacterium overgrowth and reset the normal flora. Molluscum contagiosum. So molluscum contagiosum is this flesh-colored papular rash that is generally dispersed over the trunk. The characteristic of molluscum is these flesh-colored lesions that have central umbilication, like an umbilicus. You can kind of see this lesion has some, but that's the characteristic look of molluscum. Molluscum generally occurs in kids. They're usually painless. They can be a little bit itchy. They're self-limiting, but look how long they last, almost a year. So if they're persistent or causing a problem, like just a couple of them are like, say, getting caught like on your t-shirt or something like that, then you can do cryotherapy or put salicylic acid on them repeatedly or some retinoids to knock them down. But generally they're just a self-limiting, but you'll see a lot of kids with these because parents get concerned about that. Fungal infections and candidiasis. So vulvovaginal candidiasis is the most common cause. This is this cottage cheese type discharge. There may be some redness or satelliting lesions around the perineum. It occurs due to increased estrogen levels, can occur with oral contraceptive use and pregnancy. Can occur when you're using antibiotics, glucocorticoids, have diabetes, HIV infection, intrauterine devices, or a diaphragm can also cause these infections. This is a KOH prep. So a KOH prep is basically you're scraping some epithelial cells, trying to get some of this fungus here to look at under the microscope. And what you do is you basically take the skin scrapings and put them on a microscope slide. And then here's your little skin scrapings. And then you put potassium hydroxide over the top and a slide cover, and the potassium hydroxide eats away all the epithelial cells, and then you look at it under the microscope and you see this. This hyphae is what they call it. So these little fungal branches, more or less, that you can see that, and then maybe the budding yeast, which let you know that you're dealing with a tinea, and you're not dealing with a bacterial infectious process. There's a diaper rash. So these are what they call the satelliting lesions. We'll see more of this in peds, but that's your classic diaper rash, primarily caused by a fungal infection because it's moist and dark. Balanitis is associated with the penis. There are these white patches, cause severe burning and itching, can also be in the thighs, gluteal folds, and buttocks, but that would not be called balanitis. It would just be a fungal infection of those areas. But candida has candida, so yeast really likes these dark, moist, warm areas, and so those are sites that are particularly vulnerable to yeast infection. So there's an example of balanitis. So this infection is causing cracking and irritation here, probably changing the pH, and does not look very comfortable. Here's what they call intriginous candidiasis. So this is in the axilla. There's interdigital candidiasis. So fungal infections from dermatophytes. So dermatophytes are not the same as yeast. So what we're just looking at is all the yeast infections. Now we're talking about tinea. So not actually yeast. This is actually a fungus caused by a dermatophyte, which is a different type of fungus, but it's not a yeast type fungus. And so that wet KOH prep was actually showing dermatophytes, but not just yeast. So that would have been more like a tinea infection. So there's more tineas than you want to know. There's that KOH prep again. So potassium hydroxide is used to prep, to look at the infectious process under the microscope. You want to accurately identify, because these can be misidentified as a dermatitis, and then you just feed the fungus with steroid and the fungus goes nuts. So something to keep in mind. But yeah, ringworm is not susceptible to nystatin because ringworm is not yeast. It is a dermatophyte. So preventing fungal infections, well, you want to keep the sites dry. You want to have clean clothes. You want to find correct fitting clothes, not too tight, not too loose. You don't want to share personal items, and you want to treat athlete's foot. So here's tinea barbae. So this is just a tinea infection from, this is where this guy's shaving a lot. The dermatophytes are destroying the keratin, and the protein, that protein keratinous substance is gone, and that makes the skin tough and irritated and allows bacteria to get into some of the other areas. So common causes are Trichophytum rubrum, Trichophytum verrucosum, and Microsporum canis. Basically, it's just treatment with an antifungal, usually an oral antifungal, for about 6 weeks to treat this type of tinea barbae. You'll also see this on people's necks too. Difficult to differentiate from folliculitis. Sometimes you treat it like folliculitis and then see what happens. And then if it doesn't get better, then you treat it like tinea barbae. Tinea corporis, so that's just a tinea infection of your body. If it's extensive or the person is severely immunocompromised, they may need to use an oral antifungal. If they fail topical antifungals, then you can also put them on orals. Remember that extensive cases of tinea corporis may suffer from underlying disease. So if they're really bad, you might want to start thinking of some underlying pathology that may be present, like diabetes or an immune condition. Here's tinea corporis. So this is like on somebody's neck line. This is like what we hear about ringworm. So you get this nice ring of tissue. Usually it might be more annular looking, so circular, and usually it's these raised borders. And what they say is this centralized area of clearing, and that's kind of the hallmark there of that. So topical antifungals, and then if you have to, you can do orals. This is tinea pedis, so that's a really nasty case there of athlete's foot. So not very comfortable. Basically topical antifungals. You want to make sure that their feet aren't very wet, that they're drying their feet well and washing in between the toes with soap and water, making sure that they're using dry socks all the time. Tinea capitis, so this is ringworm in the scalp. There's this black dot tinea capitis. That's from Trichophytum tonsurans. Basically, topical antifungals in the form of griseoflavin are the treatment of choice here. We'll cover this also in peds. A lot of this is going to carry over into peds, so just be aware that with derm, there's a lot of overlap, but that's good because I think it takes a few times of hearing this information to really get it. So tinea curis is a dermatophyte infection of the groin. There's a red area of skin that spreads out, and the creases of the groin, the border of the rash may consist of a small line of raised blisters. So this is what it looks like. Looks super itchy and not very fun. So basically the treatment is to apply a topical. You also want to make sure that they're like pat drying when they're done with the shower and things like that. Constantly changing underwear, but not easy. This is somebody's backside, probably sitting a lot or sitting in like a wet diaper. So that's unfortunate because that would be really hard to get rid of. There's a tinea curis under somebody's testicles. So that looks just super uncomfortable. But the take home here is here's these satelliting lesions. Okay. This is kind of like petechiae too. So this is caused by a dermatophyte. So you'd want to put them on an antifungal, not a yeast cream. Tinea versicolor. So tinea versicolor, they call it versicolor because it's not red like that. It's this almost hypopigmented areas on the chest or back. Kind of looks like a cheetah print, but it's lighter, not darker. So what they suggest is this ketoconazole shampoo, which is Selsun Blue. So what they do is they take Selsun Blue and they lather their body in it. They leave it on for like an hour, and then they take a shower and rinse it off. And they do that for about 7 really to 14 days. So there's also oral antifungals that are helpful if they're unable to do the selenium sulfide biz. Vitiligo. So vitiligo is idiopathic loss of the melanocytes. The melanocytes aren't working properly, so you get these blotches, and they quit producing melanin in these areas, and that's why the skin is super light. So vitiligo, people at increased risk of social and psychological distress, so keep that in mind. They also can end up with skin cancer or sunburns in the area where they don't have the melanin. They can have eye problems such as inflammation caused by iritis and hearing loss. So to diagnose this, we want to do an ANA, a CBC, and a skin biopsy. Treatment can be corticosteroid creams, and then this like tacrolimus will also help with UVB light. That could cause, if you're exposed to too much UVB light, it can cause lymphoma or skin cancer. So you want to be careful, but there's basically some different treatments for vitiligo, but the take home is usually there's not a lot that helps. This is melasma. So melasma is hyperpigmentation. So hyperpigmentation of the cheeks. Generally where we see this, the treatment is hydroquinine. That's first line. You can also use tretinoin and corticosteroids. Azelaic acid is also used and can help kind of shed some of the keratin and help the tissue not look so hyperpigmented. There's chemical peels, microdermabrasion, laser treatments, and light-based procedures, all of which kind of shed the outer layers of skin. So that's melasma, hyperpigmentation. Actinic keratosis, so now we're moving into our pre-cancer cells. So an actinic keratosis is this rough, dry, scaly patch of skin, usually less than 1 inch, so about 2.5 centimeters in diameter, flat to slightly raised patch, a bump on the top layer of skin. In some cases, it's hard or wart-like surface. The color is varied from pink, red to brown, and it is this kind of scaly, crusty appearance. It can be itching and burning in the affected area. This is considered precancerous. Actinic keratosis risks include being over 40, living in a sunny place, exposure to intense sun or sun tanning, or using a tanning booth. Persons with red or blonde hair, blue eye color are more at risk. People that freckle when they burn, personal history of actinic keratosis or weak immune systems. Actinic keratosis is a precursor to squamous cell carcinoma. This is a different type of skin lesion. It's called seborrheic keratosis. So this is it's a widely variable appearing lesion. The difference between actinic keratosis and seborrheic keratosis is that seborrheic keratosis are not cancer, but the difficulty here is they look like melanoma a lot of times. So sometimes we have to biopsy these and make sure that it's not a melanoma. So SKs are non-cancerous. They do have this kind of stuck-on appearance. The older you get, the more you get. The treatment is to biopsy them. You can use cryotherapy to remove them, but unlike actinic keratosis, they do not have to be treated, but you do want to differentiate them from melanoma. Skin neoplasms. So now we're moving on from precancer to cancer. So the cancers are basal cell carcinoma, squamous cell carcinoma, melanoma, and Kaposi's sarcoma. Basal cell carcinoma is the most common form of skin cancer. It arises from the basal layer of the epidermis. Common malignancy in Caucasians, almost 20-1 for basal cell carcinoma. Basal cell carcinoma is linked to exposure for UV light, especially during childhood. So the presentation is about 70% of people will present in some area that is exposed to the sunlight or UV light. Most common presentations are a nodular superficial form. They account for about 90%. Usually presents as a shiny, pearly, or translucent nodule, usually red, pink, or white in fair-skinned individuals, but tan, brown, or black in more deeply pigmented individuals. So basically, on lighter people, it presents lighter. On people who have a darker skin tone, it presents darker. So here's a presentation. Basal cell carcinoma. This guy's got a basal cell right here. Basically, it's an open sore that oozes and bleeds and crusts. It remains open for at least 3 weeks. It may be a reddish patch. It might crust and itch or hurt. Slightly elevated. It may have a rolled border, and it may have some tiny vessels in the center. Has a white or yellow-white waxy area with poorly defined borders. So these are so difficult to look at words. Pictures is worth 1,000 words. That's so true for dermatology. So treatment for basal cell. Sometimes these tumors will metastasize, but not very often. They can invade to the surrounding structures. Treatment usually consists of excision, burning it electrically, cutting it out, using liquid nitrogen to freeze it, or performing a Mohs procedure if it's deep enough. What the Mohs procedure does is they basically, you've got this lesion, right? Say this is your nose. There's the nose, okay? You've got this lesion and the dermatologist comes in here, he cuts it out little by little. Each time with each cut, he goes deeper and deeper and deeper. And as he's cutting deeper and deeper, he's taking this and going to his little microscope and he's looking at it to see if there's cancer cells. And then he scrapes a little deeper and looks and scrapes deeper and looks until he doesn't see any more cancer cells, and then he's done and he stitches you back up. There's other kind of topical creams. This fluorouracil cream is a chemotherapy type of cream. So when do we biopsy basal cell carcinoma? Well, if it's uncertain, we're obviously going to biopsy it. Basically, any skin lesion that's concerning to you, you need a biopsy so that you can find out what you're dealing with. You want to consider if they've been out in the sun a lot, if they have previous malignancies. The Mohs microscopic surgery is the standard for excision of basal cell. So there's another basal cell. These are just some facts regarding basal cell, but there's this kind of a reddish telangiatic kind of lesion, mainly in Caucasians, increasing worldwide and due to exposure to light, particularly in childhood. So here's some different basal cells. I mean, the morphology is just so vast, it's difficult, but this is a superficial basal cell, a pigmented basal cell, a nodular basal cell, morphoic basal cell, and a basosquamous cell. Okay, squamous cell carcinoma. So squamous cell carcinoma is basically this lesion that you have that does not heal. So it's like an ulceration that never heals, an open sore that never heals. So you can see this just looks like a sore, like somebody burned her with a cigar, but this just never heals. And so can also be from a burn or petroleum byproduct radiation, but somehow the skin is damaged, and as that skin is proliferating again, then you get this lesion that will not heal. So the hallmark, like I said before, was just an open sore that does not heal. My computer keeps trying to go into sleep mode. And it's a double computer system, so bear with me here. Get a little 1 minute break.
Okay.
So continuing on here, cutaneous squamous cell carcinoma. So squamous cell carcinoma is the second most common skin cancer and is cured with local therapy over 90% of cases. So basically, we want to identify this soon because there's a higher potential here for local reoccurrence than with basal cell carcinoma. The hallmark of squamous cell carcinoma is this open sore that we already talked about that does not heal. Diagnosis for squamous cell cancer, we want to be suspicious if they've previously had skin cancer, if there's any bleeding or crusting, if there's evidence of sun damage to the skin, tender or itchy non-healing areas, erythematous papules or plaques, flesh colored or erythematous plaques, dome-shaped nodules, any other kind of these concerning eosinophilic, funginating, or verrucous nodules or plaques. 4 basic types. So actinic keratoses is a type of squamous cell carcinoma. Then you've got squamous cell carcinoma in situ, which is considered Bowman's disease. Bowen's disease, invasive squamous cell carcinoma, and metastatic carcinoma. Spreads to different parts of the body. Treatment options include surgical excision, cryotherapy, electrosurgery, and radiation therapy. Other options for treatment include chemotherapy with this topical 5-fluorouracil, and then radiation therapy as well. To follow up on, basically, careful follow-up to make sure that there's no metastasis. You may refer these people out. Dermatology usually will handle most of that. You want to reassess in 3 to 6 months and do total body skin exams on these people. Melanoma. So melanoma is a potentially lethal type of skin cancer. There are 4 main types: superficial spreading melanoma, nodular melanoma, lentigo melanoma, malignant melanoma, and acral lentiginous melanoma. Increased risks of melanoma, obviously, if you're exposed to the sun. If you have a lot of atypical nevi, that is also a risk factor. And family history of melanoma always makes you more concerned that could be the case. Early signs of melanoma and assessing melanoma, we want to look at what they call the ABCDE rule for melanoma, which is asymmetry, borders, color, diameter, and evolution. So are the borders symmetric or not? If they're asymmetric, it's more concerning. If the borders are irregular, it's more concerning for melanoma. If the color is variable, or what they call variegated, that's more concerning for a melanoma. If the diameter is greater than 6 millimeters, that's also more concerning. And if the lesion is evolving, that's more concerning. This ugly duckling sign is a sign that if one of the lesions, if the patient has a bunch of atypical nevi and then one of those lesions does not look the same, that's the ugly duckling sign, and that is also suspicious. Here's the types of melanoma. So superficial, nodular, lentigo, and acral lentiginous. Superficial spreading melanoma, nodular melanoma, lentigo, maligna, acral. So that's going to be on the palms, soles of feet, and in the nail beds. Key factors to consider: the tumor thickness. The more penetration the tumor, the more likely to spread. 10-year survival rate is 99% for patients with melanoma in situ, and will almost always be cured by excision. Less than 10% with metastatic disease lives beyond 5 years. 8 to 10% of melanomas arise in people with a family history of disease, and histological findings of ulcerations or mitotic rate are also significant features. So the mitotic rate is how quickly the cells are turning over. Sentinel lymph node is something that sometimes they'll excise to see if the melanoma has spread to the lymphatic circulation. Treatment options, chemotherapy, immunotherapy, and then kind of this targeted therapy, which these NIBs are monoclonal antibody type medications that help treat that. Kaposi sarcoma. Kaposi sarcoma is related to herpes human virus 8. It arises commonly in persons with immunocompromised, Central Eastern European descent, younger individuals, women, and also in other geographic areas, but mostly in Central and Eastern Europe. Related to AIDS, Kaposi sarcoma is a diffuse pattern with adenopathy and a poor prognosis if it's AIDS related. Here are some presentations of Kaposi sarcoma, these purplish, reddish blue, dark brown or black skin lesions, macules, plaques, and can be mostly on the lower extremities, but can be all over. Description is slow growing, localized, indolent, however, can become disseminated and rapidly grow and cause significant morbidity and mortality if that should occur. So diagnosing is via biopsy. Here's some more pictures. Slow growing, localized, however, it can also move around. You can do radiographic staging to stage how advanced it is. Here's another form. There's somebody's wrist. Total skin exam. So the total skin exam is basically a complete body check of a person's skin, kind of like these little monkeys do this preening stuff. So the objective is to detect early melanoma and other skin cancers, always perform in a standardized sequence so you don't miss anything. You want to include the scalps, palms, soles, groin, and digits. Baseline skin examination, so that way you kind of know what's normal for that patient. Should be done in middle and older age men with light skin complexions. You want to instruct the patients on how to perform a self-skin examination as well. If you find anything concerning that you're not comfortable dealing with, then you send them to dermatology. You use the ABCD rule to assess for badness. You can do excisional biopsies if the lesion is 1 to 3 millimeter margins of normal skin for initial excision of suspicious lesions. Incisional biopsy may be acceptable for larger lesions. And then you can also do a punch biopsy or a shave biopsy. Sunscreen, you basically want to wear your sunscreen anywhere from 15 to 50. SPF 30 or higher is recommended for outdoor activities. Most provide UVB and UV2A protection. Only avobenzene, zinc oxide, and titanium dioxide protect against UVA1. There are many combinations, mainly for cosmetic reasons. Proper use includes a liberal amount, about 1 ounce per adult, with repeated applications every 15 to 30 minutes before sun exposure. Reapplication every 2 hours after swimming or sweating. UVB is more closely associated with melanoma development. That is it. That is a lot of information. So I want you guys to go over this one more time, make your own notes. This will be a really good, this is probably the biggest lecture in the derm series. The peds lecture will have a lot of overlap, and derm 3 is not as hefty, but does kind of tie up some of the loose ends also. So if you're comfortable with this information by the end of the day today, you'll be doing very well. So go back over this lecture at least a time or two and do the reading and make sure that you can answer all the questions from the study guide, and you'll be in good hands.